Welcome everyone. Hello and welcome to our live session today. I will be going over a quick starter presentation before we begin to welcome you all and introduce you to our program and various opportunities if you have, of course, not attended any of our previous shadowing sessions. I do want to highlight that Pre-Health Shadowing is a student-led, minority-led, women-led nonprofit dedicated to helping prospective healthcare professionals gain access to educational resources, no matter their demographic status, abilities, or location. My name is Jesus. I am the Chief of Program Planning here at PHS, and I want to thank you all for attending today. So now let's get started. Okay, there we go. Just a little PSA, we do have closed captioning for all of our sessions to accommodate all students. This setting is available on the bottom of your Zoom screen, and if you need assistance enabling the transcript, please direct message one of our student members. We are always looking for ways to be more inclusive and ensure our sessions are accessible to everyone. So please, if you have any recommendations whatsoever for how we can improve, you can email us at info@prehealthshadowing.com. So, since this is an international program, we want to know, where are you guys Zooming from today? You can you can write in the chat. If you could do me that favor. Okay, I can see, okay, we have people from all over. Okay, that's wonderful. Okay, thank you guys so much. I myself am calling from the wonderful island of Puerto Rico in the Caribbean. If you want to stay in the loop, you can follow us on social media. We are active on both Instagram and TikTok, or you can also sign up for our email list on our website to never miss a session. So we do have some wonderful opportunities for you all as benefits of being part of our program. One of those being our pre-health research program that will allow students to connect with PIs or principal investigators as they conduct research in a plethora of topic fields and locations. This program is 100% remote, which means you have the power to connect with anyone. This is an 8-week program that will become available, on June 21st. For more information, you can fill the interest form that was sent in the chat below, and we will get back to you as soon as possible with additional details. We have also partnered with Kaplan to get our students a 10% discount code that can be used on all Kaplan products, as well as free resources, such as study guides to help you prepare for your standardized tests like the MCAT, the NCLEX, or the PCAT. If you fill out our short survey, in the chat, we will get sign up for these deals for free. And we would also like to draw your attention to another amazing program that is Neolith. Neolith is an online mental health platform for students. For pre-health professionals especially, we know that the path isn't easy, and that is why we have partnered with Neolith to spread the word and offer free access to their services if you use the link in the chat or enter the code PREHEALTH when signing up. Additionally, we are really excited to announce that we have partnered up with Krispy Kreme for you to purchase one delicious dozen donuts to enjoy with your loved ones. With a donation of $10, you'll be able to receive your treat while also helping us at PHS. More information and instructions can be found by clicking the link that was also sent in the chat. We also just got our PHS merchandise, which we are very excited about. This is another way to help our organization and acquire a really nice piece of clothing, that being t-shirts, long sleeves, or hoodies to represent PHS and our mission. So we invite you all to check our merchandise. Mask for Mask is another amazing women-led organization that donates 4 masks for every 4 masks sold. These go to people in need during the COVID-19 pandemic. For example, those in the homeless community, healthcare workers without their proper equipment, and others who are struggling to stay safe. With our discount code PHS15, you can get 15% off your order. If you buy through this method, Pre-Health Shadowing will also get 10% of the proceeds, which is amazing because, as I mentioned earlier, we are a nonprofit that runs solely off of the support of our community. If by any chance you want to play a bigger part in supporting PHS, we would love for you to join our network of student volunteers and team members. You can apply to be part of our administrative team and lead students in various projects and initiatives with professional outreach, grant writing, and a lot more. We, of course, understand that as a pre-health student, you may not have the time. So we also offer the opportunity to volunteer asynchronously with tasks that can be done on your own time. We would definitely love to have you be part of this program and contribute your own unique perspective. Good news, if you are a high school student and you want to get involved, we have started a program called HTP, or High School Training for PHS, which allows you to connect with college pre-health programs, get involved in fundraising for PHS, and organize resources for other high school students interested in medicine through PHS. We also want to recognize the hard work of all of our students here in the program. So if you are interested in getting published, you can submit essays, reflections, research papers, and reviews to our editor-in-chief through the link that was dropped in the chat to have your work on our website. This will definitely look great on CVs, applications, and resumes, so do take advantage of it. Part of our mission here at PHS is to promote diversity. And in order to do this, we have launched an initiative to have monthly panels to celebrate different demographics in the field of medicine. Some of these upcoming events include a series on patient experiences, a COVID-19 roundtable, and international student forum. If you have a mentor, professor, or professional that has inspired you in any way and you think they could contribute to these conversations, nominate them today using the link that was dropped in the chat. If you can, we humbly ask that you donate to our program. As you know, Pre-Health Shadowing is completely student-run, and we are working around the clock to keep this free and accessible to everyone. Unfortunately, Zoom and our website are not free, so any contribution you can give would be greatly appreciated. If you are not financially able, we request you send this link to someone you think can, so we can continue to support those who cannot afford similar opportunities. Just a little announcement throughout the session today, we encourage you to drop any questions you may have for the speaker in the chat. And our team members will be taking note of these to be asked in the latter half of the session, that is the Q&A session. We advise you to take good notes as our professional is going over their presentation, as there will be the chance to, as there will be the chance to take a post-shadowing assessment to verify your virtual shadowing hours. More information will be available on this at the end of the session, so stay tuned. And lastly, if you can, we request you turn your cameras on. This is by no means an obligation, as we are respectful of different circumstances, but it does help us feel closer together in a time when socially distancing is mandatory. We also request that you make sure to mute yourself, as this will ensure the professional has the complete and full attention from the audience. Now, I appreciate you all for listening, and I would like to welcome Dr. Jeremy Kukafka. Thank you so much for joining us today. You may share your screen whenever you are ready.
All right, thank you for the introduction, Jesus.
You're welcome.
All right, can you hear me?
Yes.
Okay, great. And can you see my screen?
Also, yes.
Okay, wonderful. Now, before I start, there's a couple of times where I'm going to be asking questions, and all right, I can see the chat now, so I'll be able to monitor that. Okay, wonderful. Is it all right if I start?
Yes, of course.
Okay. All right, everyone. Thank you for the invitation. It's a real pleasure to be able to speak to you all this afternoon. I'm currently in New Jersey, so it's about 1:10 here. I saw someone else was from New Jersey, so go New Jersey. So the title of my talk is Cardiac Anesthesiologist. And when I was in your shoes at your stage, I had absolutely no idea what an anesthesiologist really did. And I certainly did not know what a cardiac anesthesiologist did. And I certainly did not know that cardiac anesthesiologists existed and they were a thing. So who am I? This is what I look like. My name is Jeremy Kukafka. I'm a physician. I'm a practicing cardiac anesthesiologist, and I'm also a teacher. So those are the two professional passions that I have. And I currently work in an academic practice. I'm the associate professor of clinical anesthesiology and critical care at the Perelman School of Medicine, which is at the University of Pennsylvania in Philadelphia. And just to get things off, I love what I do. And I think whatever you decide and whatever path you take, I think this in the end needs to be your goal. Because everything else can easily turn into a job, and anything else can easily become tiring and become fatiguing unless you have a real passion for it and a real love for it. And I'm really kind of privileged and lucky, I think, to be able to say that now I'm in my 13th or 14th year of practice, and I still love what I do, and I'm excited to go to work every day. So what I want to do today is kind of describe my path. You know, how did I get to where I am now? How did I become a cardiac anesthesiologist? I'd like to describe what an anesthesiologist is. I think the vast majority of our society has very typical perceptions of what it means to be a physician, and an anesthesiologist does not typically fall into that category. Usually it's something like the primary care provider or the pediatrician, but there are many fields in medicine which don't meet that mold. And I want to describe to you today what anesthesiology is, because it's what I do and it's what I love. And also want to describe a typical day. So first, I want to get, if you can, in the chat, just so I have an idea, where are you all students now? Okay, great. So there's a really nice representation of different types of schools, sizes of schools, and where you are geographically. And the other question is, what are you studying? Like, what's your major? What are you studying now? All right, cool. So a lot of biology, some neuroscience, biomedical sciences, healthcare. Someone's doing an MPH, biochemistry. Okay, great. That's very helpful. And the next question is, what are your career aspirations? Meaning, what's your end goal? You know, you're here hopefully because this is enjoyable to you, but you're also here because this is going to help you to reach an end. So what are your career aspirations? Wow, a neonatal anesthesiologist. That's pretty cool. CRNA, MD, some kind of physician, a neurologist, OBGYN, cardiovascular thoracic surgeon, pediatrics, chronic pain, OBGYN, cardiac surgeon. Okay, well, I'm very happy to say that what I will be talking about today will be very relevant to most, if not all of you. Okay, so let me talk a little bit about where I started. I'll start in college. No need to go earlier than that. I went to the University of Rochester, which is in upstate New York, just south of the Canadian border. And I went to college with maybe an idea about medicine, but that's more along the lines of that's what my family told me that I should be doing ever since I was very, very young. What I really loved was physics, and I studied physics. And my goal was to be a physicist. But the more I did physics, the more I love physics. And the more I work with physicists, the more I realized that maybe I love physics, but I didn't necessarily love being a physicist. So I still had my eye on medical school throughout, and I tried to keep the biological sciences relevant and by getting a certificate in biological physics. Actually, let me go back. One of the things that I want to kind of stress or emphasize when you're kind of thinking about what to study, what to major in, as far as a path towards medical school, there's really no right major. And non-traditional majors are becoming just as common as quote unquote typical majors like biology type majors. So do what you love. And this is your one opportunity to really study it and to really learn it. And you'd be surprised how applicable most things that you can study in undergraduate for your career in medicine. All right, so what did I do in college that allowed me to get into medical school? Well, this is what I think happened. This is the stuff that I think medical school liked about my time in college. I was passionate, and I think that's really key. Whatever you do, and it's very clear for the folks here running this program, there's a real passion there. And I think if you can have that passion and convey that passion, that goes a very, very long way. I was very involved in teaching. I kind of discovered early on that it was just a lot of fun. And I really enjoyed working with students and being an educator. A lot of what I did was in a group learning format. So I think that was really good and was looked at very positively because most of medicine is collaborative. And you're working with a lot of different, not only fellow physicians, but there's all sorts of folks that have a role in taking care of our society, and a lot of what we do is very collaborative and working with everyone. I did well in my studies. I think just the reality is you got to get good grades. So I did well there. In things that I got involved with, I had leadership, and I think that's important. And I had some research. Right now, I'm would not categorize myself as a researcher, but I didn't know that was what I wanted to do or not. I think if you do get involved into any kind of research, I think it's important to have something to show for it. Meaning, as opposed to being a part of a project versus being a part of a project and having something like a publication or a presentation or an abstract or a poster, something like that. I think that makes a big difference. Medical school, I went to Robert Wood Johnson Medical School. At the time, it was part of what was called UMDNJ, which sounds like alphabet soup. It stands for University of Medicine and Dentistry of New Jersey. It was part of the New Jersey State Health System, which was Rutgers. So not too long after I finished medical school, the name was Rutgers. So I went to Robert Wood Johnson Medical School at Rutgers University, and I had a great experience there. So there in medical school, and this isn't just the medical school I went to, this is medical schools all over the country. Really, they do a number of things. One, which is very objective, you get the foundation of knowledge of what you need to be a physician, not to be a practicing physician. People don't go to medical school and then graduate after 4 years and practice as a physician. That doesn't happen anymore. It's been a long time since that was the model. But you get the foundation, and the foundation is what you need to go to the next step, which is your residency training or whatever type of specialty you decide to pursue. The other thing that happens in medical school is you transition as to what kind of a person you are in society and what role you have in society. I like to use the kind of take from the military. You really transition from a civilian, which is what everybody is, to a physician. And there's a lot that goes along with it. I can give an entire separate course on that, which I've been involved in the past. But essentially, you are privy to aspects of people's lives which they don't share with anyone else. You are responsible for people like no one else is responsible for. And it takes a lot to kind of mentally and emotionally transition to having that role. So that occurs during medical school, and it kind of continues to occur throughout your training and your career. The other thing that happens in medical school is you really ask yourself, what do you want to do when you grow up? Because the reality is being a doctor can mean all different things. My life as a cardiac anesthesiologist is very different than my wife's life. My wife is an OBGYN, and what we do on a daily basis is often kind of similar, especially in the hospital work on the labor floor, but can be completely different when my wife is in the office doing routine gynecologic care, as an example. So you get exposed to all these things in medical school, and you really get to figure out what matches your personality, matches your goals, and matches what gives you that happiness. So hopefully down the road, you'd be able to say that you love what you do. So I didn't really think I wanted to be an anesthesiologist. When I did my first kind of basic science time in medical school, which you get kind of this basic background of, I shouldn't say basic, fundamentals of really the science and the physiology and the pathophysiology before you're in the clinical wards. I was drawn to cardiology, and a lot of it came to what I loved about physics, I think. A lot of it was fluid dynamics, a lot with flow and valves and resistance, and I just kind of assumed, like a lot of people do, that if you like the heart, then you became a cardiologist, and that was that. So really, what happens after these kind of basic fundamental science years in medical school, you go through the clinical years. And during those clinical years, you get exposure to different fields. The courses in which you get exposed to these things are called clerkships. So you get exposed into internal medicine, for example, surgery, pediatrics, OBGYN, neurology, psychiatry, among others. And you get to try things out, and you get to see whether or not you think this is something that you enjoy, what you'd be good at, and whether or not you think that this is something that you wanted to pursue as a career. So I did an anesthesiology elective. A lot of the subspecialties are not part of the main clerkships, but you have the opportunity to experiencing them. There are many subspecialties that fit in this category. And when I did my anesthesiology elective, I just was excited. It was pretty cool. Like, it was one of these things where at night I was reading and looking up my patients for the next day, and I woke up with kind of this fire in my belly, and I was just really happy to get up and go to the hospital, even though it was still dark out. And to me, that said a lot. So really, I think a key there is to trust your instincts when deciding on a career path, because I just felt it and I just loved it. And when I look back to kind of analyze it, it really had a lot of the aspects of cardiology that I enjoyed, without some of the aspects of the field that really was not something that I enjoyed as much. It was just very, very high yield in the aspects of cardiac physiology, pathophysiology, and the operative environment I really liked as well. All right, so let me start by saying, really, what does it mean to be an anesthesiologist? What do we do? And one of the things that I said to myself when I entered medical school, when I was initially thinking about fields, was I really didn't want to be an anesthesiologist, because I didn't think anesthesiologists needed to have interpersonal skills. And I think interacting with people and interacting with patients and forming those bonds is incredibly gratifying. And I didn't want to not have that in my career. So the question I ask you guys, and you don't need to put this in the chart, this is kind of a rhetorical question for you to just think about, is, do anesthesiologists need to have interpersonal skills? So let me give you an example here. So this is a true story. This happened not too long ago when I was on call. We have a 59-year-old woman who had advanced lung disease, for a lung transplant. She's been on the list for 2 years. So 2 years with severe lung disease, waiting for a lung transplant, during which time she had worsening shortness of breath and increasing amount of oxygen that she was having to use at home. So I'm going to be her anesthesiologist, and I'm going to take care of her. And my role is to keep her alive as each of her lungs is replaced. So I get into the hospital. This is at nighttime. We were doing this operation, and I meet her, and she's with her daughter for the first time. So you can only imagine the value of being able to have interpersonal skills and being able to relate and comfort and inform your patients in that scenario. So here's another one, a little different. So 42-year-old patient, gentleman, with a life-threatening aortic emergency. This is called an aortic dissection, which is a tear of the main part of the main aorta as it leaves the heart towards the rest of the body. Arrives to my operating room via a helicopter. This is a true emergency. When I see him, he's brought in by the helicopter paramedics. He has difficulty breathing. His blood pressure is very low, which is due to a blood building up around his heart and increasing the pressure around his heart and not allowing it to fill and pump effectively. After talking with him briefly, he has a family, which is what he tells me. One of the first things he says to me. He has 3 kids, and he's terrified. So I meet him for the first time. And I think you can imagine there the importance of being able to relate to people in that scenario. So my exposure to those kinds of things really did demonstrate to me that anesthesiologists have an incredible role in caring for their patients from an emotional perspective, and your interpersonal relations have a great deal to do with their outcomes. The other aspects to understand is that patients give up complete control while under the care of their anesthesiologist. And this is rare in medicine. Most of the time, and this is very appropriate, when a patient goes to a doctor and there's a discussion about a care plan, what tests should be done, what therapy should be done, should there be an intervention, and the discussion is back and forth. And probably most of the time, the patients will agree with what the physician is recommending or prescribing. But it doesn't have to be that way, and the patients can decline or say, I don't think that's right for me at this time, as an example. But the key is that there is an interplay. When a patient is under the care of an anesthesiologist, essentially what a patient is doing is giving the anesthesiologist permission to care for them when you as the patient are not able to make decisions for yourself. And that level of giving up control is rare, and you as the anesthesiologist really need to have the ability to earn their trust for patients to be able to give you permission for that. So really, as an anesthesiologist, you completely sustain the life of another human being while you're in their care. And just to summarize this kind of aspect of anesthesiology, really the best anesthesiologists can relate well, bond very quickly and gain trust, ease the severe amount of anxiety. My patients in the cardiac surgical arena, when patients come to me and they come for heart surgery, they are keenly aware of their own mortality. And they know that I may be the last person that they speak to. And thankfully, that's not the common. That is still an unusual event, mortality in cardiac surgery, depending on what the operation and the patient comorbidities. But the likelihood is there, or the possibility is there, and patients are aware of that. And you need to be able to convey critical information very efficiently and compassionately. All right, so as an anesthesiologist, you evaluate patients preoperatively. When they come for surgery, they do not leave their medical problems at home. People have medical baggage per se. And you need to be knowledgeable about really an incredible diversity of medical and surgical problems. Patients can come to you with significant cardiovascular disease, lung disease, kidney disease, liver disease, unusual neurologic disorders, and you need to know not only what they are, but how to manage them and how to manage them in the acute care setting, which is either the operating room or in intensive care. So these are just some examples of things that you need to be able to know about, and not only know about, but also optimize preoperatively before you care for them. So, like I said, cardiovascular disease, pulmonary disease, renal disease, which is kidney disease, bleeding problem or blood problems, neurologic disease, and problems which can occur during pregnancy for obstetric pathology. So what you're asking yourself is this. You're saying, is the patient ready for surgery? And if the patient is not, what tests or intervention? need to happen first? So here's an example. You could put the answer in the chat. We have a patient for elective surgery, and the patient has shortness of breath with stairs. You say, how have you been feeling? And you go through the whole list, what's called a review of systems, where you discuss, you ask questions in all the different organ systems, and you learn that the patient is feeling like just short of breath when they take stairs, which is kind of new. On physical exam, you listen with your stethoscope and there's a heart murmur. And you ask the patient about it and they're not aware of any heart problems. So what do? Do you A, say, okay, let's proceed with surgery and assume things will get taken care of? B, do you proceed with surgery and say, you know what, you really need to see a cardiologist after this operation, so you recommend for follow-up post-operatively? Or you say, you know, we're not doing the operation today, we're going to cancel it, or we're going to do testing, or we're going to order a cardiac ultrasound. So what do you guys think, A, B, or C? All right, everyone said C. And in this scenario, C is correct. And the reason is that there's new symptoms with a murmur, and that actually is an indication for cardiac testing prior to elective surgery. Now, that being said, not all problems would require canceling the surgery and get testing beforehand. Most things, actually, most symptoms would as long as you have the information in order to care for them optimally, most things can have further workup post-operatively. But you are correct. In this case, because of a concern for severe valvular disease, this patient had aortic stenosis, which was unknown, is going to get a cardiac ultrasound, is going to diagnose the aortic stenosis, and is actually going to get an intervention to treat the aortic stenosis before getting this elective surgery. So, all right, nice job, everyone. All right, so just to summarize, you need to optimize the patient's medical problems, and you need to manage these problems both during and after surgery. Okay, now, as the anesthesiologist, you need to decide what to do as far as prescription of what type of anesthetic. So this is where the concept of anesthetic choice comes in. The options really are general anesthesia, which I'll discuss all of these, so I'm just kind of listing them now. General anesthesia, neuroxial anesthesia, which consists of spinals and epidurals. You could do regional anesthesia, which is the numbing up of, the blocking or anesthetizing of peripheral nerves, or monitored anesthesia care, which is a level of sedation which is supplemented at the surgical site with local anesthetic infiltration. So here's another question, and please answer in the chat. What characteristics do patients have when under general anesthesia? A, unconsciousness. B, being amnestic, meaning not having any memory. A, kinetic, no movement. D, analgesic, not feeling any pain. Or E, all of the above. All right, so everyone's putting E, and that was an easy one. It was a leading question, because you never have something like that when more than one answer could possibly be right, and there's an all the above, and all the above is the right answer. So here's another question, and this is something for you to think about. This is rhetorical. You don't need to put it in the chat. But what is the difference between being under general anesthesia and being dead? Mostly similar. So two big ones. One is that it's reversible. And two is that the patient's alive, meaning you need to be able to maintain all of their physiologic symptoms. You need to make sure that they have enough, that they're oxygenating, that they're ventilating, meaning breathing breaths in and out, that they have a blood pressure, that they have a heart rate, that they have a rhythm, that all of their organ systems and functions are working and functioning optimally throughout. And then at the end, patient has to be reversed to a state at least as good as when they started, ideally. And if you can optimize, then that's all the better. So the other, and this is just my plug that I need to say there, is that if you look at the medical innovations throughout our society's history, the introduction of general anesthesia is one of the greatest contributions to all of medicine. Think of every procedural intervention that's done currently. Any type of operation, any type of intervention, any type of procedure, Without the ability to anesthetize somebody, none of that would happen. If you could think of cancer therapies, if you think of cardiovascular treatments, neurologic treatments, none of those things would be available to us today without the invention of general anesthesia, or discovery, I should say. All right, so let's move on to neuraxial anesthesia. So here, essentially, instead of anesthetizing the brain, you're anesthetizing the spinal cord. And if you look at the picture to the right, what these do, they represent dermatomes, which are areas where the nerve of the body where the nerve innervates, and the nerves that I'm referring to are the nerve roots, which are the nerves that come out directly from the spinal cord. So if you anesthetize the spinal cord, or the nerve roots as they immediately come out of the spinal cord, then where along the spine you anesthetize, you can anesthetize various parts of the body. So you can, for example, put a catheter in the epidural space in the lumbar spine region, which is the low back region, and you can give local anesthetic and medicines into that space, and patients can be kept comfortable during labor, as an example. All right, so you can also do surgery. You can place that lumbar epidural that I just spoke about, and you can anesthetize somebody's lower extremities, and patients can get surgery while awake. They can get a knee replacement if necessary, which is kind of remarkable. And patients don't necessarily need to have general anesthesia, and some of the things that could be associated with that, which could be negative for certain individuals, or patients can be sedated. Cesarean section is another classic example where patients are awake. They have a neuraxial block. Usually for elective cesarean sections, there's something called a spinal, where you inject local anesthetic into the spinal fluid, also in that lumbar spine area, and patients can be completely awake and be able to have an abdominal operation and have a cesarean delivery, and not only be awake to experience the birth of her baby, but also not need to have systemic medications give, which can be transferred to the baby and potentially have a negative effect after the baby is delivered. Neuraxial anesthetics can be used for pain control. So you can have the catheter in that epidural space, and it could be used afterwards. It could be used after surgery. It doesn't necessarily need to be surgery. It could be after traumatic injuries. And generally, when you compare this towards systemic pain medicines like opioid medications, you do have superior pain control. You have lower side effects, and you can reduce or avoid administering opiates at all. All right, regional anesthetics is essentially the way I like to think about this is you're kind of going down the line. So instead of anesthetizing the brain for general anesthesia or the spine for neuraxial anesthesia, you're now anesthetizing peripheral nerves. And peripheral nerves you can really think of as the nerves that travel throughout your body after they leave your spine. So it could travel down your shoulder, down your arm, down your legs, as an examples. And when you inject local anesthetic and surround those nerves with local anesthetic, whatever part of the body that nerve supplies, or innervates as it's called, becomes blocked, and you can anesthetize various parts of the body. So this is an example here. This is the clavicle here. This is someone's this is a right shoulder joint. This is a right humerus. And by injecting the brachial plexus, which is the group of nerves, as it travels underneath the clavicle, you can do a block called an infraclavicular block, which is very useful for operations involving the upper extremity or the arm. And patients can be awake or just lightly sedated and have surgery there via that nerve block or regional anesthetic, and also have outstanding pain control afterwards without much use of opiate medications. So here's a patient for below the knee amputation, meaning that the leg below the knee is going to get cut off. This gentleman, unfortunately, has severe lung disease. So think about what it means to have a general anesthetic with severe lung disease and let's see what anesthetic plan you would prescribe. So would you prescribe general anesthesia? Would you prescribe a regional anesthetic or peripheral nerve block? Or would you prescribe sedation for this? All right, so everyone's picking B again. So either my questions are very, very easy, or I'm just conveying the information that I want to be able to convey to you guys. Either way, it's fine. So I would personally, in this scenario, do a regional anesthetic. I think a general anesthetic is not an absolute contraindication. The risk of it is that the patient would need to be intubated and have a breathing tube placed into the trachea or the windpipe and be placed on a ventilator. So that in itself can have complications or potentially have a lower likelihood of a quick recovery in somebody with severe lung disease. So a regional anesthetic where you block the nerves to the leg, you can have a patient be awake or lightly sedated and not have to be placed on a ventilator. So here's an example. This is an example of injection in various parts of the leg in order to anesthetize that lower extremity with the nerve block. So really, it's kind of amazing what you can do with a syringe and needle and a little bit of local anesthetic medication in there. So again, you can avoid intubations, you get superior pain control, and you could avoid opioid medications. All right, so that just kind of reviews the concept of anesthetic choice, just to give you an idea or an understanding of what goes into these kind of broad stroke decisions that we make when we see a patient preoperatively and we prescribe what kind of care prescribe the type of anesthetic care that we're going to be providing for our patients. And also just to review that what we do, part of the role as anesthesiologists is we need to control and manage the life-sustaining functions of patients. So this is an example. One of the things that anesthesiologists are expert in is airway management. The reason is that a lot of the medications that we give, although they're given safely countless times over, they're inherently very dangerous. And one of the ways that they're very dangerous is that they can impair a person's ability to breathe, impair a patient's ability to have an open airway, meaning have a path for air to exchange from the outside environment into their lungs. And it often goes so far as to completely obliterate the drive that a patient has. So if you give those medications that induces general anesthesia and you're not able to secure an airway, then you have a life-threatening situation. So this is an example of intubation, essentially where an endotracheal tube is placed via the patient's mouth through the hypopharynx to the back of the throat. Here it's through the larynx into the trachea. This is a laryngoscope, which is the most common device that's used in order to place the endotracheal tube. All right, so things that the life-sustaining functions that we manage, really you can group them into respiratory. These are the most common. Respiratory, where you're managing somebody's airway. You need to know how to work ventilators, prescribe the proper ventilator settings, not only in healthy patients, but in patients with the wide variety of lung disease that we as human beings can suffer from. Also cardiovascular, which includes blood transfusions, fluid administrations, medications to support the heart, medications to support blood pressure. And again, this isn't only in people with normal heart functions, this is in people with all sorts of significant cardiovascular disease. And pain control afterwards is the realm of the anesthesiologist. So I would say all anesthesiologists are experts in pain management. There is a subspecialty out of anesthesiology in being a pain medicine physician, which I'll discuss those in a little bit. But all anesthesiologists are experts in pain management. All anesthesiologists are expert in the safe prescription of opiates and opioids, and all anesthesiologists learn procedures in order to manage pain. So an example of that would be nerve blocks, which we discussed just earlier. It's a multidisciplinary field, which I think is a lot of fun, meaning I'm not sitting in my own world and only talking to other anesthesiologists. We work as part of a team, and that team consists of surgeons, it consists of medical proceduralists, such as cardiologists or gastroenterologists, The team consists of nurses, pharmacists, surgical and medical technologists, and many other that aren't on this page. And that is kind of, I think, something that's very enjoyable to be able to work in that collaborative environment. Anesthesiologists also can work in very diverse practice locations. I work in an academic medical center, but you don't have to. You could work in a community hospital, which could be a very large community hospital offering most or the same things that most of the academic medical centers can offer. You can work in a small community hospital. You can not necessarily work in a hospital, but in freestanding surgical centers, or you can work in medical offices. So these options are all part of our field, and you would have the ability to choose and tailor your practice accordingly. So anesthesiologists are specialist consultants. So what kind of specialists do we have? Well, actually, let me go back for a second. I mentioned continuity of care. So this is something that you will decide what kind of field you want, meaning, do you want to be a consultant where you're referred for your expertise? You care for the patient within that scope of practice of your expertise, and then the patient would return to their primary care provider as an example. Or do you not want to be the consultant? Do you want to be the primary care provider where you're the individual who will have the continuity of care? Patients will most likely refer to you as quote unquote their doctor or their physician. But when it comes time to specialty care, you're the one that's going to be referring them outside of your care to another individual's care who has that expertise, and then they will come back to you after that problem that's taken care of. And that's one of the things that you will be deciding and thinking about as you kind of go through your education and decide what kind of career path you want to take within medicine. These are some of the specializations that you can choose as an anesthesiologist. I'm going to go through them briefly just so you have an idea of the scope of practice of anesthesiology and what it is that anesthesiologists do. Critical care, pain medicine, pediatric anesthesiology, regional anesthesiology, neuroanesthesiology, obstetric anesthesiology, and this is what I do, and I'm completely biased. I think it's the best field out there, cardiac anesthesiology. So critical care physicians care for the critically ill. This is the field that you can get to through multiple pathways. Anesthesiology is one of them. Medicine, surgery, emergency medicine, those are other pathways to being a critical care physician. You take care of critically ill patients, essentially. They're typically either medical patients, surgical patients, trauma patients. There has been an increased public awareness of what critical care physicians are and the importance and the role of critical care physicians in our society during this COVID-19 pandemic. Pain medicine physicians, they're experts in pain. They get extra training. They're experts in both chronic and acute pain management, which can include cancer pain. This is often an office-based practice, meaning you have your own office and patients come see you in an office environment. There are often procedural interventions in addition to medication prescriptions, where you become an interventionalist and you perform procedures on patients to alleviate their pain. There has been an increased societal awareness of pain medicine physicians as well, and this is due to the opioid epidemic over the past number of years. Pediatric anesthesiologists, they're experts in the care of pediatric patients getting surgeries, essentially, or surgical interventions, or oftentimes diagnostic procedures, because what is not painful and okay for an adult may be incredibly uncomfortable or scary for a child. And the main thing that you'll learn is that kids are not just adults that are just small. You have the option to work in pediatric specialty hospitals, and you're a component of the multi-specialty anesthesiology. You can be a component of a multi-specialty anesthesiology group where you'll have adult anesthesiologists and pediatric anesthesiologists, and you often have the ability to practice both. Regional anesthesiologists, I spoke a bit when I talked about regional anesthetics. You specialize in performing these blocks, and you have extra training and you have an extra expertise in this. You have a expertise in management of acute pain. Trauma is a common scenario for that. And this has also gained an increased awareness during the opioid epidemic, because patients now have the option to have their pain relieved and get surgery with minimal or no use of opioids. So that certainly has an increasing role in public awareness and patient desires. I have more patients now that come to me that request either minimal or no opioids than I've ever had in my career. All right, neuroanesthesiologists, they specialize in the care of patients getting neurosurgical interventions. They're experts in neurophysiology. And there is an increased public awareness of this when you're talking about postoperative cognitive dysfunction. The kind of classic story of this is, grandma was really sharp until she needed this surgery done. And now she just doesn't seem to be the same anymore. And is it the anesthetic? Is it the surgery? How do you prevent it? Are there any kind of interventions that could be done or withheld in order to minimize the incidence of cognitive dysfunction after surgery? And obstetric anesthesiology, they specialize in the care of patients of women having babies, labor, vaginal delivery, cesarean section. They're experts in maternal and fetal physiology. This is another example of when just because a woman is pregnant and having a baby doesn't mean that she doesn't have other medical problems. And you become the expert in managing those other issues, such as cardiac disease or diabetes or kidney disease or lung disease, for example. It's a lot of spinal and epidural anesthetics. And my personal opinion of this field is that it's a great ego boost. And you can walk in and meet a patient for the first time, and she is in an extreme amount of pain, and with a relatively quick procedure and an injection of medication, you can completely wipe the state that pain away, and you have a patient who's comfortable and lucid and able to experience the birth of her baby comfortably. And you get a lot of props from patients for doing that. And it feels good to be able to do that for people. Cardiac anesthesiology, this is what I do, and I'm completely biased in favor of it. What you do is you care for patients undergoing cardiac surgery. You also take care of patients with severe cardiovascular disease getting non-cardiac surgery, because somebody with severe cardiac disease or having a ventricular assist device or had a heart transplant may still need their gallbladder out. So who's going to be taking care of those patients? And you're experts in both cardiovascular disease and cardiovascular pharmacology. You're an echocardiographer, so you make diagnoses of cardiac disease, you guide the interventions, you assess the interventions. And this is a picture of the left ventricle. It's a transesophageal echo, which is like an endoscopy. It's a camera that goes in the mouth, down the esophagus. In this case, it's into the stomach, and you can see the left ventricular wall. One aspect of the ventricle is contracting very well, and some other aspects not so much. So this is a patient who had a major heart attack that I was taking care of. You're also, as a cardiac anesthesiologist, an expert in mechanical cardiac assist. This is a picture of a cardiopulmonary bypass machine, also known as a heart-lung machine. This is very similar relative to something called ECMO, which is an acronym. It stands for extracorporeal membrane oxygenation, which can be used to support and keep a patient alive when their lungs no longer work, when their heart no longer works, or both their heart and their lung no longer work. And this, for the first time in my career, has made the lay press, and public are aware that this thing called ECMO exists, and it can keep patients alive when their lungs don't work. And that's directly a result of the COVID-19 pandemic and patients who are supported with ECMO with severe COVID lung disease. You're an expert in ventricular assist devices, which is kind of an artificial heart and artificial hearts. Mechanical assist to treat heart failure is very young, and it's a very, very active and exciting field to treat heart failure. So let me tell you a little bit about a day in my life, and then I'm going to stop talking soon so I can field any questions. I get to the hospital at 7 a.m. Never in my life would I ever think I would have a job where I have to be somewhere at 7 a.m. But I like getting there at 7 a.m. And that, I don't know if it's a consequence of me not being in college anymore, but when I was in your shoes in undergrad, I would never, ever, ever dream of wanting to be anywhere at 7. But that's what I do, and I have fun doing it, and I'm completely used to it at this point. I change into my scrubs, so you get to wear pajamas every day to work, and I see my patient. So this is someone I had just this past week. This is a 73-year-old gentleman for coronary artery bypass surgery. He presented to urgent care in the community with shortness of breath. He was sent from the urgent care to the local emergency room, and he was diagnosed with a myocardial infarction, which is a heart attack. And then he was transferred there to my hospital. He went to the cardiac Cath Lab, which is when they inject dye into the coronary arteries surrounding the heart to see if there are any blockages. And he was found to have severe multivessel disease, and then was scheduled the following day for coronary artery bypass surgery under my care and the surgeon's care. When I evaluated him preoperatively, he had hypertension, a high blood pressure, hyperlipidemia, which is very elevated cholesterol, and obviously he had severe multivessel coronary disease, diabetes. The heart function was mildly decreased. He had a preoperative heart ultrasound that showed it had mildly decreased function. His airway examination, which I perform before I care for anybody, because I will be intervening on the patient's airway, and I assess to see whether or not there are any indicators of it being difficult, and which would change my plan and any specialized equipment that I would need. And his physical exam was essentially normal. I placed a catheter, which is a thin plastic tube, in an artery in his wrist for direct arterial blood pressure monitoring. I gave medicines to induce general anesthesia with pharmacologic support, meaning I had an infusion of medications to support his heart and blood pressure. After he was unconscious, I placed an endotracheal tube, which is the tube from going into his mouth through his larynx into his trachea, and placed something called a pulmonary artery catheter. What that is it's a thin tube that goes into the jugular vein in his neck, and it gets the catheter gets placed through that vein into the heart, through the different chambers of the heart into the pulmonary artery, and that gives me information as far as heart function, and it gives me the ability to administer special types of medications. And then I perform something called the Transesophageal Echo cardiogram, which is cardiac ultrasound, which is delivered via an endoscopy, which is the camera that goes in the mouth down the esophagus, and you take pictures of the heart through the esophageal wall. This is my work environment. This is what it looks like. There's a lot going on when I'm in the operating room. So can you see this cursor? Can anyone tell me if I move it around?
Yeah, we can see it.
Okay, super. So I'm just going to point out a couple of things, what they are. So this is the patient. This is just his head. Usually I could see the patient more, but for privacy reasons, I pulled the drapes down. What you see here, this is the ventilator. So that corrugated tubing, which is going here, that's going into the endotracheal tube, which is going into his mouth, into his lungs. It's very hard to see here, but see that kind of yellow little thing right there? That's part of the tubing that's going into his neck. And all the tubes are connected to these things, which are pressure transducers. And what that does, that translates the pressure that's in the tubing and converts it to an electronic signal, which then gets displayed to monitors, which are all up above eye level, all the way up here for me to see. These are all infusion pumps. So these are able to administer infusions of medications at prescribed rates, medicines to either sedatives or medicines to support heart or blood pressure. And this is the echocardiographic machine, or the echo machine, which is what operates and displays the ultrasound device. And this is the ultrasound device. This is the handle right here. And this is the endoscope, which is going into the patient's mouth and down the patient's esophagus. Any questions on that, on what anything is, before I move to the next slide? Okay, I'll move on. If you have any questions, then I could always go back to it at the end. All right, so this is the patient's heart. This is again, that same cross-section of the left ventricle. The preoperative diagnosis of mild ventricular dysfunction is no longer holds true. So the patient must have been getting clinically ischemic, meaning not getting enough oxygen to the heart throughout the time from the last ultrasound exam, because here the left ventricle is barely squeezing. So this is severe left ventricular dysfunction. You can see all the walls have decreased what's called contractility or squeezing. And the surgeon did a revascularization. The coronary arteries were bypassed. And what we use to keep the patient alive is the cardiopulmonary bypass machine here. And then after the patient was separated from the heart-lung machine, he still required mechanical support. And this is a picture of the monitor for an intra-aortic balloon pump. That's a balloon that gets placed in the aorta, which inflates and deflates with specific timing with the cardiac cycle, and helps augment both heart function and also blood flow to the vessels, the coronary vessels surrounding the heart. And after we did all that, you could see the heart function is much better, which is really gratifying and very cool to see. So we finished the operation, we brought the patient to the intensive care unit, and he did quite well afterwards. He was extubated a few hours afterwards in the intensive care. He was able to safely leave the ICU the following day, and currently he's at home and he's doing well. So this is just an example of a case that I do as part of my job. It's very gratifying. You can tell it's very complicated, and the learning curve is still steep. Meaning I'm learning how to optimize things, and I'm learning new things on the regular, which is a lot of fun. So stagnation really is not a thing in my field. So in addition to clinical practice, I'm an educator. So this is an example of academic practice. You can do this in any field. What that generally means is that in addition to your clinical work, you do something else. And that something else is incredibly diverse. Everything from education to research to policy there's just an enormous amount of options that are available to you. In an academic practice, you essentially have time, resources, and the ability to pursue these interests that are related to your field, but not directly clinical work. So what do? I'm a teacher. I teach medical students at my medical school, and I introduce them to the field of anesthesiology. The concepts and what I taught you or showed you today is very similar to what I tell the medical students in the course that I run. I also train resident physicians in anesthesiology. So these are people who finished medical school and decided to be anesthesiologists, and they're doing their residency in my hospital. So I train them. In addition, I train fellows. So fellows is the term that's used for physicians who've gone through medical school, they've completed their residency, and they're doing extra subspecialty training. So during that extra subspecialty training period, you're termed fellow. So I train fellows in cardiothoracic anesthesiology. In addition, I mentor all of these individuals. So I help them with their careers, make decisions as far as what paths that they should take, and help them be able to reach their goals. So I mentor student, residents, physicians, fellows, and also fellow faculty members. Anesthesiology, just to summarize, is the field I discovered in medical school. I did not know of it ahead of time. It was not on my radar. I have a diverse yet very specialized clinical practice, and I'm a teacher, and I love what I do. All right. Thanks, anyone. Any questions that I could answer?
Thank you so much, Dr. Kukafka, for your amazing presentation. We really enjoyed so much. So students, I'd like to remind you that if you have any questions, you can type them in the chat or raise your hand to ask them directly to Dr. Kukafka. I see that Alyssa has raised her hand. So Alyssa, you can go ahead and unmute.
Yes, hi. I really enjoyed this lesson with you, and it really gave me an insight on the field of anesthesiology. And also, I would like to know, how long is the fellowship training for anesthesiology, specifically OB?
Sure. So to be an obstetric anesthesiologist, you'll go to medical school, which is 4 years. You will do a residency in anesthesiology, which is another 4 years. And then you are able to practice obstetric anesthesiology. You have the option to do an extra training in obstetric anesthesiology, which is 1 more year Most commonly, individuals who do that extra training tend to be in academic practice, meaning that they conduct research or they teach and train other residents. But I would say that the vast majority of anesthesiologists in this country that practice obstetric anesthesiology did a 4-year residency in anesthesiology and did not do extra training. So that's an option to you depending on what kind of career and practice you'd like to have.
Okay, thank you so much.
Okay, so for the next question we have over here would be, how would you describe the work-life balance of an anesthesiologist? I'm sorry.
Yeah, sure. So this kind of goes a little bit into the concept that I mentioned earlier about being a consultant. So people come to me as an anesthesiologist for my skill set and the care that I'm able to provide for them. They don't necessarily come to my hospital specifically looking for Dr. Kukafka to be taking care of them in the operating room. They come to my hospital knowing that it's an outstanding medical center and that the care of the anesthesiologist will be excellent. So there's two sides to that. So one side to that is you can look at it negatively, and you could say, well, patients are not coming to see me specifically. They're coming for an anesthesiologist. I happen to be part of a group or a health system or a hospital that provides outstanding care, but it's not necessarily me particularly. So I don't like that aspect of it. The other way of looking at it is to say, well, because of that, and because that patients come for the skill that's provided, I have the ability to transfer care to one of my partners or to one of my colleagues. So if it's, for example, the end of the day, and I would be able to transfer the care of my patient to one of my partners to continue their care into the evening, which means that I have my end of day and I would be able to be home and have dinner for my family, for example. And we take turns doing this. So we call that being on call. So when it's my turn to be on call, then I'm the person to be there at night and do what needs to be done as far as patient care. But if it's not my turn to be on call, then I can tell my daughter that I'll be at her orchestra concert and I will be there. Or if I want to go do something with a friend, that's the sort of thing that I have the option to be there. So there are a number of different fields in medicine where you have what's called a group practice model, where you have the ability to sign out the care of patients to one of your colleagues. So that in itself has a lot to be able to provide a balance between your work life and your non-work life. So I'm very happy with that aspect of it.
Awesome, thank you. Rohan wants to know why you chose UPenn over other universities.
Is this, just to clarify, is this as far as my job or for my residency training? Because I did my residency training there as well.
I guess both.
Both. Okay. So when you decide you want to, let me rephrase, when you're looking to decide where you want to go for a residency program, there's going to be a number of factors that will go into that. One of it is the quality of the training that the program provides. The other is what kind of exposure to any specialties that you might be particularly interested in. And then the other is geography, meaning what makes sense for you. Like, do you have family in Chicago there's a great program in Chicago, then there may be a good chance that you'll wind up in Chicago. So for me, I was interested in cardiac anesthesiology, and the cardiac program at Penn is outstanding. I did what's called an away rotation. So when I was in medical school, I spent a month there to get exposure and to see it firsthand. And I absolutely loved it, which is just kind of that experience that you have firsthand. And it really, it reinforced my initial perception. And the last thing, which is a big component of it, is my wife and I met in medical school, and she also wanted to be in Philadelphia. So all of those together really kind of made it the right place. But we looked all over. We didn't look on the West Coast, but we looked for residency programs all up and down the East Coast and some Midwest cities as well. And then because I really enjoyed it during my training, and I'm very much, I have a passion for education, and the educational mission and the educational culture there really is great. So I stayed, and I've been very happy since.
Wonderful, thank you so much. So another question from our audience members is, was there a role model in your life you revered and motivated you to pursue your profession? And what kinds of qualities do you suggest indicate a good mentor or model?
Yeah, that's a great question. The answer is yes, and I've had many. I think in medical school there was one individual who really stands out, and I think the number one attribute is passion. That mentor really has a love for what they do. And I think it's very much human nature when somebody loves what they do to want to impart that love onto somebody else and to get somebody else excited into what makes them so happy. So I think mentors need to not only have that passion, but have time, and have insight into who you are and what your needs are. You need to be able to have an open relationship with that individual, meaning there can't be such a power dynamic where the mentor or the mentee are uncomfortable kind of discussing things honestly and openly. And I think it's also very difficult to have a mentor-mentee relationship when there's an evaluation going on, meaning if your mentor is going to be grading you, it's a little hard to have that kind of open relationship, because in the back of your head, you're always worried about whether what you say is going to impact your grade. And I've had the opposite. I've had individuals who I very clearly said, I don't want to be like that person, and that's good too, for you to kind of see the range of practice and career models that people have, because what's right for one is not right for another.
Absolutely, thank you. We had some questions regarding anesthesia and more clinically based questions. So I'll start with that. An audience member asks, can you explain why patients may experience cognitive dysfunction due to anesthesia after surgery?
No, I cannot. This is something that is actively being investigated. It's unclear as to whether or not actually it's the anesthetic itself, or it's the entire, or if it's the surgery, or if it's the entire kind of process put together. We do know that there are certain medications, for example, that there are certain environmental factors that can make something called delirium, which is this kind of temporary state of cognitive dysfunction, worse. So we have like the tip of an iceberg approach, I guess, but we don't really understand the mechanism of true post-op cognitive dysfunction. And there's a lot of anesthesiology that we don't understand. And that's part of what makes it exciting, and why so many people get into the field who are scientific investigators.
Okay, thank you so much. There's definitely lots of research to be done. So Trung asks, have you ever encountered the situation in which a patient is allergic to a certain substance while being anesthetized?
Yes, I have, on a number of occasions. So we give many medications, often together, and often in rapid succession. So the likelihood of somebody being exposed to a medicine that they have never been exposed to before is pretty high. So when you think about the kind of recipe to have an allergic reaction, you can see that all the ducks can kind of line up. And anaphylaxis is a life-threatening reaction. It's a life-threatening situation, so you need to know how to treat. You need to know how to recognize it, and you need to know how to treat it. It's often multidisciplinary. There's a lot of people that are involved. If it's recognized and if it's treated, then the survival is very high. So in all of the patients that I've had this happen to, patients have done well. Sometimes it's patients that were not under general anesthesia, meaning that they were sedated and awake and conscious and aware that this process was happening. So it certainly can be traumatizing for individuals. And what's important is that after the acute event is over, most of the time we don't wind up doing the operation. Sometimes we have to, that the patient gets evaluated so it doesn't happen again.
Great, thank you. So a question we had from the audience was, why do pregnant patients have to receive spinal and epidural anesthetics when giving birth? Why don't we have endometrial or vaginal anesthetics?
What is the first question? Why do what patients?
Why do pregnant patients have to receive
patients.
spinal?
Got it. So essentially what you want to do is block so you could think of nerves as pathways for signals. And if you're not blocking tissue injury, you're not blocking the receptors at the site of the tissue from being activated. What you're doing is you're blocking the signal from reaching higher up in the nervous system. And when you do that, you're blocking the conscious sensation of pain, but you're also blocking the physiologic response to pain, which can lead to a stress response, hormonal release, blood pressure changes, heart rate changes, which can all have an adverse effect. So to block all of that, you really need to block the nerve. And if the farther down the pathway you go to the organ or to the body itself, then the more dispersed the nerve fibers are, and it becomes more difficult to reliably block, and the higher the amount of local anesthetic that you need. So there are ways to block for obstetric patients around the cervix, for example, when there's a contraindication to getting an injection in the spine, such as somebody with a bleeding problem. And it helps, but from experience, the efficacy is nowhere near as good.
Okay, wonderful. So following the same line of pregnancy-related cases, our audience asks, if a pregnant woman needs a non-pregnancy-related procedure, like a leg surgery, what kind of anesthesia would they receive? Would the anesthesia harm the fetus? I'm sorry.
Yeah, no, that's a very good question. That mostly depends on where in the pregnancy the patient is, meaning how many weeks pregnant the patient has been, and what stage of development the fetus is in. Once you're beyond the state of organogenesis, which is when all the organs are developed within the fetus, then the risk of exposure to medications and anesthetics goes way down. Very, very, very early on, it tends to be an all or nothing effect, meaning that the fetus, it may result in a spontaneous abortion or a miscarriage. And then there's this kind of early on range where you could potentially have defects in organogenesis. And then later on, the safety is very good. So really, whenever you have surgery or an indication for surgery in a woman who's pregnant, one of the main questions to ask is, where in the pregnancy is the patient, and what is the urgency of the operation? Usually, if the operation can be postponed till later on, or perhaps even until after delivery, then that's what's done. But that can't always happen. So, unfortunately, an example that we see of this is when there's a cancer diagnosis in a pregnant woman, and it would cause the mom harm to delay the intervention to remove the tumor until after the baby is delivered. So there you're balancing the health of the mother and the health of the baby. And the general rule ethically is that the well-being of the mother outweighs the well-being of the fetus.
Okay, that makes so much sense. Thank you. Roberto asks, where do you try to aim when injecting medication? For example, you mentioned you might inject into the epidural region to reduce pain during delivery. What about something like a nerve block?
Yeah, those are all options. So it really depends the type of where on the body you need to anesthetize, and then you look at the risks and the benefits of various types of interventions. So if you're talking about obstetric pain, then really the only option is at the level of the spinal cord. If you're talking about extremities, then you have the option of either spinal cord if it's the lower extremity, or peripheral nerve blocks as you go more distally. So you can block, for example, just below the knee area, or even you can block specific areas of the foot or specific areas of the hand. So knowing your neuroanatomy and knowing the dermatomal distribution of all the peripheral nerves, and knowing where you can safely inject local anesthetic around those nerves is all essential in order to be able to perform these blocks.
Okay, great. So Nicole asks, given the possibility of patients having a variety of comorbidities, have you encountered an unexpected issue during surgery? And if so, how do you approach such situations?
All the time. One of the things that's very kind of exciting about my field is expecting the unexpected. There are things that can happen that are life-threatening, which are rare, and you like either adverse reactions to anesthetics, allergic reactions that we talked about, to things which can be somewhat predicted, meaning somebody with severe heart disease and coronary disease, for example, having a heart attack in the operating room. So part of the reason why you do your preoperative evaluation and optimization and assessment is that you'd be able to have some prediction of what type of things may happen and what type of things to look out for. But the reality is you're responsible for another human being, and the human being has put their entire trust into you. And you need to, a common term that's used in the field is something called vigilance, is you need to be constantly aware and constantly ready to intervene. And what can happen is broad. That's a 4-year residency to learn to answer that question. But you're there, and you're there for the patient. And what I say to most people, thankfully, is that I expect you're going to do very well, but we are there for you just in case.
Awesome, thank you. Another question we had from Louis is, how is placement of the pulmonary artery catheter confirmed that it has reached the lungs?
That's a good question. So the end point of the pulmonary artery catheter is the pulmonary artery. The pathway is it goes from the vein in your neck, which is the internal jugular vein, into the right side of the heart, right atrium, followed by right ventricle, followed by the pulmonary artery. And there are different ways to verify the position. You can do X-ray imaging. You can do ultrasound imaging with the echo that I place routinely, or you can use the pressure waveform that's measured at the tip of that catheter to tell you what spot in the heart it's in. Because the waveform, meaning the pressure and the kind of fluctuations of the pressure in the right atrium is different than that in the right ventricle, is different than that in the pulmonary artery. So by monitoring that, it will also tell you where the catheter is.
Thank you. That's really interesting. So Rohan asks, how does the anesthesia process work with awake brain surgery?
So sometimes brain surgery is not done under general anesthesia, because when there's a tumor that's near a site, let's say speech, for example, you'd want to be able to test someone's ability to speak. And you can't test their ability to speak if someone's unconscious under general anesthesia with an endotracheal tube in place. So you can do this with somebody being lucid enough to answer your questions. So really what that is, it's a combination of nerve blocks to anesthetize the scalp and the cranium, and medicines which can be given to relieve anxiety and sedate patients enough so that they're able to, and this sounds kind of wild, but able to lie on an operating room table with their brain exposed, and still be able to answer questions, to be able to determine whether or not the part of the brain that's being removed is going to affect the speech site.
Yeah, thank you for that answer. I remember reading about this in one of my neurology books, and it was like, wow, I can't believe they do that. But thank you so much for your responses to the questions and your informative presentation. We're going to go ahead and start with our wrap-up presentation. So students, stay tuned so you can learn how to take your post-shadowing assessment. So because that presentation was so informative, I bet you guys have a lot to reflect on. If you could answer 3 questions, such as what brought you to the session today, what are 3 major takeaways you got, and what do you want to learn more about, that would just help you to kind of document your thoughts so you don't forget them later and maybe put them in your applications, or just considering all the things Dr. Kukafka has so generously taught us today. So this writing and reflection is not required, but if you do want to submit a writing piece, you can always submit it at www.prehealthshadowing.com/blog submissions. You can submit articles about sociological, anthropological, medical, or student life-based articles, and anything you'd like to write to pre-health shadowing. We definitely would love to get things published for you. I'm actually the editor-in-chief, so if you had anything to submit, I'd be so happy to read it. So I would like to mention once again, as Jesus has mentioned before, that we are launching a research program, and what it does is that it allows students to connect with principal investigators as they conduct research in a plethora of topics. And of course, this is 100% remote and it's free, which means that you have the power to connect with anyone. This is an 8-week program, so basically an 8-week commitment on your behalf. And we will begin on June 21st. So for more information, you can visit the link in the chat, and you can also apply on our interest form, which is also sent in the chat. If you want to learn more about pre-health shadowing or get involved, we have our asynchronous volunteering, which means that you can do the volunteering on your own schedule and time. And we have the application for the team member. So in this way, this is more synchronous, and you can lead different volunteers and initiatives and projects and get to know some of the people on our team. So all very exciting things. If you'd like to apply, please click on the links in the chat and apply to either volunteering asynchronously or being a team member. So once again, we are humbly asking that if you're financially able to donate, that you please consider sending a few dollars to our Venmo and our PayPal or our GoFundMe. It does cost a lot to keep the website running and our Zoom running. So if you know someone who can donate, or if you can donate, please support those who cannot by donating to our organization so everyone can continue to get the education they deserve. And we simply ask everyone to spread the word about pre-health shadowing to your classmates, to your friends, maybe to your professors, so they can share with everyone the wonderful opportunity of pre-health shadowing. As we know, many people have been rejected during the pandemic for shadowing, and this is always a great opportunity to get your shadowing hours and just learning about different careers in health and medicine. So now for the part we've all been waiting for, how to earn a digital certificate. So first you will be visiting the website prehealthshadowing.com, and you will be looking for our speaker session, Dr. Jeremy Kukafka, and after you do that, you can take our quick 10-question multiple choice quiz. This quiz is based entirely on the content from his presentation. There's no other information except for the live session, so don't worry about that. You will have 30 minutes per attempt to earn a 70% or higher. Once you get 7 out of 10 questions right, you get a certificate verifying your virtual shadowing hours. You get 2 attempts. Once you open the quiz, it's 30 minutes to answer the 10 questions, and you do get 2 attempts. So essentially you have 60 minutes if you do take 2 attempts. If you run into any difficulties, please contact us. And just to ensure that our website doesn't crash from a high influx of students, we ask everyone to wait like 10 minutes after the live session to take the quiz. Once you have passed, you can click the Finish Course button, which is at the bottom of the course page. And what this will do is you'll be able to download your certificate verifying your virtual shadowing hours for your personal records. on the website, if you click on your profile, you actually can see your certificates as well. So you can either download it or look at your profile on our website. We all have a record of your certificate. If you happen to miss a part of our live session today, or if you wanted to just go back and refresh your memory before taking the quiz, or did you want to look at our past sessions with so many wonderful speakers we've had in the past, and to earn more certificates, you can definitely go on to our YouTube channel. This is where we post all of our recorded live sessions, and you can also find our recorded live sessions on our professional pages on our website. And you can view any of these presentations that you're interested in, and you can take post-shadowing assessments on them in the past, whichever you want. I did forget to mention that the quiz is open indefinitely, so you can take it today, tomorrow, or next month. That's why you can also take the shadowing sessions from the past if you'd like. Otherwise, if you'd like to follow us on our social media, that would be great. We post when we're having our live sessions on our Instagram and our email list. So make sure to sign up for our email list so you're notified when we're going to have our live sessions, and follow our Instagram to see our times and dates and when we're going to have different speakers and some of the events we have. We are currently booked every weekday until the end of June. So if you are able to, please keep on track, and I hope to see you guys on the future sessions. Thank you so much for joining us today, Dr. Kukafka and all of our students. Please stick around if you have any questions for myself and my team members. Otherwise, the shadowing session is officially over, and I would like to invite you all to log off.